All right, so next up is the AR in the AR in Learn to Swim for alveolar rhabdomyosarcoma. Alveolar rhabdomyosarcoma is one of a couple of types of rhabdomyosarcoma recognized in the WHO. There's embryonal, alveolar, pleomorphic, and spindle sclerosing, which is its own category. Alveolar rhabdomyosarcoma is the small round blue cell tumor that's really going to look a lot like other things that we're going to look at here in this talk. And it's going to occur in adolescence. It's going to have a predilection for the extremities. It's going to occur in the head and neck. You can also see it in genitourinary sites. In males, you're going to actually find this in the prostate occasionally. Histologically, the thing that stands out to me as the hallmark, in addition to the rhabdoid cytology, is a picket fence appearance at the edges of these nests, and I'll show you that in a second. The differential, of course, because it's a rhabdomyosarcoma, you're going to have to distinguish it from the other types of rhabdomyosarcoma. That rhabdoid cytology, you should want to distinguish it from malignant rhabdoid tumors. By immunohistochemistry, positivity for myogenin, MyoD, and desmin is really going to help you feel confident that you're looking at a rhabdomyosarcoma. And we'll talk about how to tell alveolar from embryonal. But the alveolars, about 80% of them, are associated with fusions between PAX7 and FOXO1 or PAX3 and FOXO1. Now notice I said 80%. That's because alveolar rhabdomyosarcoma remains a histologic classification and is not strictly defined by the presence of the fusion. So you don't want to call something alveolar just because it's the fusion, just because it has the fusion, it probably is, but you don't want to not call it alveolar, if that makes sense. You don't want to call something embryonal just because it misses the fusion. You don't have the fusion. So this is one of my favorite slides in the talk because we talk about these being small round blue cell tumors. But I'll point out here, this is a met to a lymph node. And you see on the left the lymph node with these small, variably sized lymphocytes, normal lymphocytes, and maybe some histiocytes mixed in there that you'd normally find in a lymph node, and then this deposit of alveolar rhabdomyosarcoma. And I think you can see pretty well, even at this power, that the nuclei here are much larger than the nuclei in the lymph node. So we call these small round blue cell tumors, but actually alveolar rhabdomyosarcoma, the nuclei can be quite big. And you're going to see at low power, you're going to see these nests of cells. Again, these are pretty discohesive tumors, so you can see these artifactual cracks here because these cells don't really stick to each other very well, but they still have some cohesion. If you did a touch prep, you might see some clumps of cells. And you see this kind of rhabdoid cytology here where you see a lot of pink cytoplasm that's pushing the nucleus off to the side in a lot of these cells. And here's a really good example of why these get the name alveolar. Because they have some, poor cohesion, they tend to stick to the edges of the nests and line up in this nice picket fence here. And then the cells in the middle of these nests often fall away from each other in this discohesive look, and it gives you a kind of look that's reminiscent of the alveolus in a lung. Myogenin is often quite strongly positive, and when I say strongly, I mean positive in well more than 50% of the nuclei in these tumors. That's typical of alveolar, but not a rule. You can still have alveolar histology and have 30% myogenin reactivity. You can still have embryonal and still have 70% myogenin reactivity. It's not a hard, fast rule, but it's a pretty good guide. An embryonal rhabdomyosarcoma, in contrast, instead of seeing a monotonous population of cells, you'll see a lot of different types of sizes and shapes of nuclei and amounts of cytoplasm with them. They tend to have less myogenin reactivity. Now, there's a particular pattern of embryonal rhabdomyosarcoma that's really important to know about when you're trying to distinguish embryonal from alveolar, and that's the dense pattern, what's been termed the dense pattern of embryonal rhabdomyosarcoma. So here's an example. The top two of these are alveolar. The bottom two of these are embryonal. And what you'll see right away is that in the alveolar rhabdomyosarcoma, you can see that you have this nice alveolar structure like we showed just before, but you can also have areas that are more solid. And I think some of this depends on preservation and fixation, but you can have some really solid looking areas in alveolar rhabdomyosarcoma. Embryonal rhabdomyosarcoma, you tend to have this variation in the density of nuclei. So you have this very densely cellular area and you have this much less cellular area that's got this myxoid stroma. And that's a really good clue at low power that it's embryonal. But you can have areas that have what's called the dense pattern of embryonal rhabdomyosarcoma. That's where the cells, the nuclei look more packed in, kind of similar to the solid alveolar rhabdomyosarcoma pattern. But look at the cytology here. These pictures are taken at the same magnification. You can see these large, round, monotonous cells compared with these much smaller, kind of triangular to polygonal, variably sized nuclei. That's a real good hint that the cytology is a really good hint that this is embryonal. right, so alveolar rhabdomyosarcoma. It's going to be a tumor primarily in adolescence with a predilection for the extremities and the head and neck. You're going to look for that picket fence pattern at the periphery of the nest. That's going to help you figure out what it is. When you have myogenin, MyoD, and Desmond positivity, that's going to help you. Now again, 80% of these tumors are going to be positive for a fusion that involves FOXL1 partnered with either PAX3 or PAX7. That is not required to call it alveolar, because alveolar is again a histologic classification. Now, if you're trying to remember how PAX3 and PAX7 relate to chromosomes, here's a little tip. 8 plus 5 equals 13. So PAX7 on chromosome 1, that adds up to 8. PAX3 on chromosome 2, that adds up to 5. And this worked better when this gene was called forkhead. But forkhead on chromosome 13 or FOXL1 on chromosome 13. So if you're ever trying to remember which chromosome goes with which fusion, this is a good way to do it.